Good evening. Thank you very much for kind introduction. And my warm greetings to all my colleagues who joined today the TISABRI Symposium. I hope this virtual meeting will be successful and fruitful. I really appreciate the request to deliver this talk regarding TISABRI. And I want to share a couple of things which is related to observational study, mainly to observational. My disclosure is this presentation was requested and supported by biologics. And thank you very much for invitation to give this talk observational study. And let me start with first slide. My objectives is natalizumab, efficacy and safety, impact on quality of life, impact on family planning, and finally, vaccination issue, mainly related to COVID-19. You remember very well, natalizumab was introduced and approved by FDA in 2004. Is it alpha-4 integrin antagonist, which is inhibiting the white blood cells invasion in the tissue, brain and bowel. Natalizumab was registered for relapsing remitting MS and Crohn's disease. In Europe, later on, natalizumab was registered only for MS. Unfortunately, after 2 cases of PML appeared, natalizumab was withdrawn from the market by biologics, and we can see a very important pivotal study, AFFIRM, which is appeared in 2006 and helped reintroduce the natalizumab to market. Most important points of this study was efficacy of natalizumab with sustained progression disability reduction up to 42% within 2 years, and annual relapse rate reduction yearly by 68%. Also was very important statement, natalizumab looks safe. In 2007, it was initiated a TISABRI observational program, which is one of the ongoing program, and right now it's running more than 10 years. Is it looking at the result of treatment of patients with relapsing remitting MS? Is it going in the real clinical practice? Is with real life patients? It's looking at some clinical consideration as an impact of earlier versus later treatment with natalizumab, potential for disability improvement, and outcomes after discontinuation of treatment. No other disease-modifying therapies has a similar data. First enrollment of patients was starting in 29 of June 2007, and is still running. Until now, it's engaged 6,620 patients. This observational study will run until end of December 2028. Is it recruited 290 sites and going in 15 countries with 515 study investigators worldwide. And it's more than 10 years real-world efficacy and safety study on patients with relapsing remitting MS. Objective of this study is evaluate long-term safety of natalizumab monotherapy, as well as its impact on disease activity and disability progression in patients with relapsing remitting MS in the clinical practice setting. Study design is quite simple, as it conducted over 10 years. Conducted in clinical practice. Is it open label, multinational, multi-center, prospective observational study? And it's still ongoing. Endpoints, primary endpoints, long-term safety. And secondary endpoints is MS disease activity with calculating clinical relapses sustained disability progression based on EDSS, baseline disease characteristics as a prognostic indicators for disease activity and disability progression over time, short-term disease outcome as a prognostic indicator for disease activity and disability progression over time. Unique element of this study is patients who had discontinuation of Tysabri are still permitted to remain in top. And this data compatible with MS-BASE. Most important result of this intermediate result of top study is annual relapse rate reduction, which is reached 92%. And natalizumab is associated with sustained reduction of annual relapse rate over the long term. Second point is disability improvement. It seems 1 in 3 patients showed EDSS improvement during the long-standing Tysabri treatment. Regarding safety, additional to pivotal AFFIRM trial, other study came up, which as a strata study, which is containing 1,000 patients, and length of study was 5 years. Top study, 6,000 patients, and length of study currently 10 years, more than 10 years. Tigris study, 6,000 patients with length of study 5 years, and post-marketing surveillance, which is globally looking after 200,000 patients over 14 years. All this data of all this showing that natalizumab has a relatively safe safety profile. Interim analysis showed that more than 85% of patients had no serious adverse effect during these 10 years. 5%, approximately 5%, had experienced 1 or more serious adverse effect, and mainly 4% of them, it was PML, pneumonia, UTI, and herpes infection. In the same time, incidence rate for opportunistic infection, PML, and malignancy remain low. But it seems to me PML is still an issue, and many strategies was piloted and engaged to decrease, improve risk stratification. So post-marketing setting showing the first PML 20 cases was shown in 2009. In 2010, it was another 31 case, and you can see green arrows, which are showing key milestone in PML risk stratification. So last 2, you see that an updated PML risk estimate suggestion. From April 2016, this curve is remaining steady, and it seems with roughly counting 4 patients per 1,000, 4 cases of PML per 1,000 patients from 2016 till now. Updated PML risk estimate algorithm, which calculated per 1,000 patients, was based on anti-GCV antibody status, natalizumab exposure, and prior use of anti-suppressant medication. As you can see, patient with negative GCV status has a quite low risk for PML. Patient with positive status, GCV status, level of risk depend on index level, depend on the length of treatment and prior treatment with or without immunosuppression treatment patient who was receiving later natalizumab. So current evidence suggests that the risk of PML is low at index value below 0.9 and increases with substantially at value above 1.5 patient who was treated longer than 2 years. Recommended monitoring came up as well in different countries, and different regulators put type of monitoring. One of them you can see is a European suggestion. Again, is dependent on GCV antibody status. Patient with negative status usually should be monitored every 6 months in terms of lab result, positivity of GCV antibody, and yearly with neuroimaging. Patient who positive and has a treatment less than 2 years have a similar follow-up. Patient who doesn't have prior immunosuppression treatment has a similar follow-up as previous two. And patient who has a treatment more than 2 years followed more rigidly and have additionally brain MRI, abbreviated MRI protocol every 3 to 6 months, which including T2 study, FLAIR study, and diffusion-weighted imaging study. Several years back, again, was proposed by one of the program, Touch prescribing program, proposed extended interval dosing to decrease PML risk in the real world. So US regulators trying to minimize risk of PML suggest to all prescribers, all infusion sites, and patients receiving natalizumab be enrolled in this program. So right now, this program counting more than 90,000 patients up to 1st of June 2017. Unfortunately, I don't have other data. Main 3 risk factors was calculated is anti-GCV status, prior immunosuppressant use, and Tysabri exposure time. Unfortunately, Touch research doesn't capture clinical efficacy. Objective of this program to determine whether extended interval dosing is associated with lower PML risk compared to the standard interval dosing. Patients, as I said, it was more than 90,000 patients enrolled in this Touch registry. 35,000 of them is GCV positive, and around 15,000 has a profound Touch CT analysis. If we look at the graph, which is reflecting the data of Touch registry, the extended interval dosing improves situation with PML up to 60 months versus 24 months with positive status. So it looks as a 94% reduction in PML risk just achieved with extended interval dosing. A couple of studies was busy with quality of life. One of them, top study, which is I was looking at the functional system improvement and function within first year of treatment, 3 years of treatment, and 8.5 years of treatment. The pyramidal, cerebellar, mental, and visual system was checked, and approximately 5,000 patients was reviewed. It became clear that at year 3, 50% of patients had improvement in all these 4 systems, an additional 25% after treatment 8.5 years. Energy study, another one who was looking at quality of life, they was looking at treatment with Tysabri and fatigue. Despite Tysabri itself can cause fatigue based on side effect profile, but here after 1 year, visual analog scale for fatigue improved significantly. Other studies, Swedish registry, which was reviewing cognition and treatment with Tysabri, show improvement, 10% increase from the baseline until 24 months with treatment, with regular treatment of Tysabri. Family planning, another serious issue when we're choosing disease-modifying therapies. And luckily, Tysabri has a most favorable profile in terms of family planning. As you can see, comparison between Tysabri, Fingolimod, Lemtrada, Cladribine, and Ocrevus, Tysabri practically can be used, doesn't have an effect on fertility, doesn't need contraception, and during treatment, doesn't need contraception after last dose. It might be even used during the pregnancy with appropriate benefit risk assessment. Unfortunately, not recommended for breastfeeding during the treatment. Vaccination became a serious issue, especially in the COVID time. Generally, we're vaccinating patients with MS, and it's usually depend on vaccine safety, vaccine type, potential disease trigger, we're usually looking at the type of disease-modifying therapy, infection screening, vaccine efficacy, infection susceptibility, and patient factors as age, disability, infection risk. COVID brought another view on all this vaccination. And right now, it's depend on the availability of vaccine characteristic, type, inactivated, attenuated live, or mRNA, safety and efficacy profile. Patient characteristics as well play a role as age, COVID-19 infection risk, comorbidities for COVID-19 severity, effect in current previous DMT treatment on vaccine effectiveness, as well as disease characteristics as current previous disease activity, disability, disease course, potential for COVID-19 to trigger disease activity. And finally, disease-modifying therapies characteristic. In the end of January, National MS Society States published this statement regarding COVID-19 vaccine guidelines for people living with MS. Please pay attention, this statement was released only for mRNA vaccine in the United States, for Pfizer and for Moderna. And the authors recommending to vaccinate patients with MS. European experts as well released a statement regarding vaccination, and they emphasize it's likely to be safe for patients with MS, as it looks like safe for general population. But at the same time, patient who has an immunosuppressive therapy as a S1P modulators or anti-CD20 therapies might associate with a blunted vaccine response. But even blunted vaccine response is likely to be protect patient against COVID infection. So they're generally recommending the vaccination. So overall, if I want to summarize, Tysabri looks very efficient and very powerful medication with relatively safe side effect profile. And currently, it was treated around 200,000 patients. We know the PML is issue, and luckily with all this risk stratification, situation is not getting worse. Other problem is COVID vaccination, and since we start to vaccinate patient in the after the appearance of vaccine in UAE, in our clinic, vaccinating patient usually with Chinese vaccine, this vaccine we have. We will see what will happen with Pfizer vaccine, what is the long-term safety profile for Pfizer vaccine. So I think it's still open chapter for all of us, and it's learning curve. Thank you very much, and I would like to finish my presentation.